Hi all. So today I'm going to go through the Hypercure implant, the subtalar joint implant, or we call the subtalar joint arthroeresis. So this is what it looks like. Looks like a little screw. And it comes in different sizes. I think size 6 and 7 are the most common. That's what it looks like at the end. That's what the driver will go into. So you see in the video to come the actual procedure of it. So I thought what I'll do is just tell you when I use these things. I only use them when orthoses and footwear fail to relieve pain in patients. The majority of the patients that I see that require this are the ones that have tib post dysfunction, usually stage 2, where the deformity is still flexible and there's no osteoarthrosis in the subtalar joint or the metatarsal joint. If there's any arthritis in those joints, this thing is not going to work. So the foot has to be, once again, the deformity has to be reducible with no osteoarthritis. So how does the thing work? So if we have a look, during pronation, what happens is, as the arch goes down, the talus will plantarflex and will adduct out of the foot. As the talus plantarflexes and adducts, you will also get calcaneal eversion, and the forefoot will do the opposite. It will then go into abduction. You can get those patients with flat feet that look like they got the too many toe sign. I don't think I can reproduce it with the model. The Hypercure stops the talus from plantarflexing and adducting on the calcaneus, so it fits in to the sinus, into the sinus tarsi, into the canal itself. And if we have a look at it, so there's quite a large opening. The sinus canalis is sort of oblique and it goes in there into the lateral aspect of the foot, and then it actually has a smaller opening which is just next to there. So it's near the subsentaculum tali, and that's where it will exit. So if you put this little bolt in between the talus and the calcaneus and you've got the right size, once again, it cannot plantarflex and it cannot adduct. If the talus cannot do that, then the arch stays up and the calcaneus doesn't evert. Now, when someone has been pronating for such a long time, so they've been really down, when you lift up the arch, sometimes what they'll have is they'll have quite a large forefoot supinatus. So when you put the Hypercure implant in there, post-operatively, sometimes they've got a forefoot supinatus and you need to allow for this. And you can allow for that by putting them into an orthotic with a forefoot varus posting and then gradually decreasing the posting as the forefoot comes down to neutral, as that forefoot supinatus reduces over time. Sometimes I'll use taping as well. I'll tape down the first ray to decrease that forefoot supinatus post-op. So when is this device not indicated? Once again, if there's osteoarthrosis, it won't work, so the foot has to be mobile. If there is a true forefoot varus, you wouldn't want to use this, or the forefoot will be off the ground. So if they have gastroc equinus, you may need to get them to stretch the hell out of their calves before putting this implant in, because if you don't, then they can start to get calf muscle strain or arch strain. So if you can't stretch it out, then sometimes I'll perform a gastroc recession along with the Hypercure implant. You also have to be careful in patients who are really hypermobile. So the really hypermobile patients, sometimes this thing can pop out. In obese patients, it can also sometimes pop out. So you've got to really make sure it's driven in there and the soft tissue tightened to make sure that it doesn't come out. It's very important for the patient also to have frontal plane deformity, so there's eversion of the calcaneus. So some people are very pronated, but the actual calcaneus is quite vertical. They may have quite a significant amount of drop and they may have the too many toes sign, but the actual calcaneus is vertical. Now, if you put the Hypercure implant in there and it takes that vertical calcaneus and inverts it, then the patient's not going to tolerate it very well because it's very difficult to walk with an inverted calcaneus. So these are the things that I look out for before putting the implant in. And let's have a look at the procedure itself now. The range of motion of the foot.
Yes.
Alright, and then we'll just pause it.
Okay.
So the interosseous ligament's been cut. We're going to put the guide wire in for the hypercure. Okay, there's the wire in, and it's heading towards the subentacral tali. Let's get a sizer. So we've got the size 6. Let's try a size 6 first, and then we're going to compare it to how it was without anything in there.
Oh, sorry.
Okay, let's take it through its range of motion. And you can see that it takes away a lot of the eversion. And the foot is pretty much, as I swing it around, it just wants to dorsiflex up at 90 degrees. If we take it back out, that's how it looks like without the subtalar joint arthroeresis. So let's try a size 7. And there's literally no eversion whatsoever now. It's quite hypermobile. If we have a look through here, we can see that he has quite a bit of a supinatus with the size 7. And it does go down, but it's difficult. Let's try the size 6 again. So one thing we don't want to do with this is overcorrect. And there's a little bit more eversion with the size 6. And the supinatus comes down a little bit easier. I reckon 6, huh? Let's take this out, and we're going to use the size 6. So, yep, size 6. There's the hypercure implant, the subtalar joint arthroeresis. Putting it onto the guide wire now, slipping it into the sinus tarsi and then into the sinus canalis. That's the driver. Put the driver in there. And then taking the guide wire out. Let's look at the motion again. You can see how it's quite different to when the hypercure is not in there. Eversion is limited quite a bit. That's it. Done.